Hello, it's Amit Pawa here. Thank you for joining me for this talk on practical local anaesthetic pharmacology and local anaesthetic systemic toxicity, which I delivered at the Isura Regional Anaesthesia Workshop in October 2025 in Toronto, Canada. I've got my usual disclosures here. And in 20 minutes, I hope to cover a refresher on local anaesthetic pharmacology. We'll talk about common local anaesthetic agents and when to use them, and then the influence of drugs on onset, duration, and intensity. And finally, we'll finish up on local anaesthetic systemic toxicity. I'd like to highlight this paper, this great paper by Taylor and McLeod in BJA Education, which goes through a really lovely overview of pharmacology of local anaesthetics. But let's start off with this little refresher here. So as you know, nerves transmit electrical signals to and from the central nervous system, and we've got myelinated fibers that conduct electricity faster due to the nodes of Ranvier, and we've got A alpha, gamma, beta, and delta fibers that carry the associated sensations there. We've also got B fibers that are the autonomic preganglionic nerve fibers, and we've got slow unmyelinated C fibers which carry that dull skin and visceral pain. What happens when you have a surgical incision or trauma? Well, you get this inflammatory soup which activates nociceptors, the free A delta nerve endings, which generate depolarization due to activated voltage-gated sodium channels, and then you get this rapid influx of sodium and efflux of potassium down their electrical and chemical concentration gradients, and then when you hit that membrane potential, you get an action potential generated which transmits that pain impulse. Now, local anaesthetic drugs block this depolarization by their action on voltage-gated sodium channels, and I'm going to show you the complex structure of the voltage-gated sodium channel. You can see it's got an alpha and beta subunits, and it exists in different phases, resting, activated, and inactivated phases. Now, there are 10 genes that code for voltage-gated sodium channels, and they're all susceptible to local anaesthetics, but the NAV 1.7 and 1.8 are highly expressed in sensory neurons. You can imagine those sodium channels that are in the heart, they can explain why local anaesthetic acting on those channels can cause local anaesthetic systemic toxicity. Now, this is a relatively complex overview, so I boiled it down to something a little bit more simple here. So you imagine local anaesthetic comes across in this ionized form. The unionized crosses the cell membrane and then binds to the local anaesthetic binding site, and that stops this influx of sodium into the cell. So you can see that process here. It's only the unionized part of the local anaesthetic that crosses the cell membrane and is able to act in its ionized form on the local anaesthetic binding site. So now let's cover the local anaesthetic agents. You may or may not remember that local anaesthetics have a lipophilic aromatic ring and a hydrophilic tertiary amine. But the thing that distinguishes the two different groups is that intermediate link, and that splits them into two groups, the esters and the amides. And I've been told, because I've been giving this talk in Canada, that specifically in Canada, the amide local anaesthetics that are used most often are lidocaine, mepivacaine, bupivacaine, and ropivacaine. Now, I've put this L in brackets next to ropivacaine because ropivacaine that is available commercially is the levo form. So bupivacaine, you know, is a racemic mixture of levo and dextro versions. In the United Kingdom, we have levobupivacaine, but the ropivacaine that is available is just the levo version of that. So I'm going to focus just on these highlighted amide local anaesthetics for the rest of the talk. So we often talk about pharmacological properties of local anaesthetics, and we often start off by talking about the speed of onset. Now, the speed of onset is determined by the pKa, and I'll explain that in a bit more detail later. The potency and also the toxicity is related to lipid solubility, and the duration of action relates to protein binding. So if we start on the pKa, you'll hopefully remember that Henderson-Hasselbalch equation that's shown at the top. All local anaesthetics are weak bases, and they are ionized when the pH is less than their pKa, which for all of these agents is the case, and our body pH is 7.4, so all local anaesthetics are ionized in the body. Now, the pKa is the pH at which the ionized and unionized local anaesthetics are present in equal amounts. So the higher the pKa, the greater the ionized local anaesthetic fraction, therefore the slower the onset. The lower the pKa of a local anaesthetic, the greater proportion is available in its unionized version, and therefore you have a faster onset. So let's have a look at this in a table here. You can see that lidocaine and bupivacaine have lower pKa's. Their pKa's are closer to pH, so you have a greater proportion of those drugs available in the unionized version, and hence they have a faster onset of action. But also, I want to highlight the molecular weight here. The smaller the molecular weight of the local anaesthetic, the more rapidly they diffuse through the membranes, and that also is another reason why they have a faster onset of action. Next, we're going to talk about lipid solubility, and again, this is closely related to potency and to toxicity. So lipid solubility is expressed as a partition coefficient, and high lipid solubility means you get rapid diffusion to the site of action. And you have a look over here, you can see that as the partition coefficient increases, these drugs are more potent, so you need less of the drug in terms of mass in order to make an effect. The other thing I want to point out here, if you look at the partition coefficient of ropivacaine, it's lower than that of bupivacaine, and that might explain why you have less myelinated motor fibre penetration and why ropivacaine is said to be a little bit more motor sparing. Now we're going to look at protein binding, and local anaesthetics are bound to alpha-1 acid glycoprotein. The higher the protein binding you have, the longer the duration of action. Again, look at this table over here. You will see that ropivacaine and bupivacaine have a higher protein binding, which means they have an increased duration because there is lower bioavailability. But protein binding can be decreased by certain conditions, such as hypoxia, hypercarbia, acidemia, and this means in those circumstances there may be an increased toxicity risk. So now let's look specifically at these agents and compare them. So we've got lidocaine and bupivacaine, the short-acting agents, and bupivacaine and ropivacaine, those intermediate-acting agents. So lidocaine and bupivacaine have low protein binding and a lower pH. Bupivacaine and ropivacaine have high protein binding and a higher pH. So this means that lidocaine and bupivacaine have a shorter duration and a faster onset versus bupivacaine and ropivacaine that have a longer duration and a slower onset. So surely it's simple then. For short, less painful operations, use lidocaine and bupivacaine. For longer, more painful operations, use bupivacaine and ropivacaine. Well, actually, it's a little bit more complicated than that. You could consider, if it's an analgesic block, you could use a lower concentration, use 0.25% bupivacaine or 0.2% ropivacaine. And if you're using an anaesthetic block, you use the higher concentration to get a larger mass of local anaesthetic administered. And then when it comes to continuous infusions, use a more dilute solution. So you could use 0.125% bupivacaine and 0.2% ropivacaine. Now there's another paper here that I'd like to introduce. That QR code will take you to that paper. And they've talked about looking at package inserts and using pediatric doses as a guide. And these are some guides you could consider to using the maximum amount of local anaesthetic you could administer. So for bupivacaine, this particular paper recommends using 0.23 milligrams per kilogram per hour for your continuous infusions, but making sure you don't exceed more than 400 milligrams in 24 hours. And for ropivacaine, you've got a bit more space. You can use 0.4 milligrams per kilogram per hour or a maximum of 770 milligrams in 24 hours. This is assuming a 70 kilogram patient. But are there any situations where you may desire another option? So going back to my simple version of maybe for short operations using lidocaine and bupivacaine and for longer operations using the bupivacaine or ropivacaine solutions, but what happens if the operation takes longer than anticipated? And then what are you going to do about post-operative pain? If you use lidocaine for a short operation, of course the anaesthetic dose of lidocaine will wear off, but we've got to think about post-operative pain. If you're using a longer acting solution, these take longer to set up. And what happens if you haven't got a block room? But also, do patients want to have an insensate limb for more than 18 hours? So let's handle the block room situation. So I work in an environment where we don't have block rooms. So if we're doing a block for surgical anaesthesia, we have to site the block and let the block cook. And because we haven't got a block room, we are aware of the impact this has on efficiency. So many people will say, just use the longer acting drug and wait for the block to cook. Well, this is not always practical. They can delay the list, and if you say to somebody, let's start early, that involves getting lots of people to come in early to make this process work, so it doesn't always work. We're often under pressure from our team to make sure the list doesn't finish late, and delays in while waiting for the block to cook can be significant, and our managers want us to make sure we get through the workload and not cancel patients. So if you are able to save minutes on a high turnover operating list, these small incremental savings in between cases, if you can do something to speed the onset of a block, can actually save up a significant amount of time. The other bit I wanted to touch on is, do patients want an insensate limb for more than 18 hours? And these two papers here have highlighted the fact that actually patients don't like having long-lasting numb extremities, they don't like that long-lasting lack of control, and they have a fear of paralysis and nerve damage. So, what are the options for a quick onset block so you're not waiting ages for the block to cook, and to create a situation where you get anesthesia longer than bupivacaine and lidocaine, but not quite as long as bupivacaine alone? Well, maybe now it's the time to talk about that controversial subject about mixing local anaesthetics. So how can we mix local anaesthetic? Well, the thing that many people would consider doing is doing a proximal block with short-acting local anaesthetic and distal blocks with long-acting local anaesthetic. So thereby, when the main part of the brachial plexus block has worn off, the patient still derives analgesia from the long-lasting distal blocks. The other option is to put two local anaesthetic drugs into different syringes. So do your brachial plexus block initially with lidocaine, and then the same location via a separate syringe administer bupivacaine. Now that's, whilst you're not mixing outside the body, you're certainly still mixing inside the body. And what the majority of mixers do is mix two local anaesthetic drugs in the same syringe and put them in the same location. Now, the mixer's dream is to create a solution with a fast onset like lidocaine, but something that produces a dense block when you're mixing two different drugs like bupivacaine with lidocaine or mepivacaine, but also to get that Goldilocks block duration that's not too long, not too short, but just right. The problem is, as in this paper over here, there are many quoted reasons against mixing. For example, the fact that the pharmaceutical compatibility of the solution you've created has not been proven, the fact there are risks of precipitation and crystallization, that we don't have good recommendations on the dosing, and that some of the additives and preservatives can be neurotoxic. They also complain that admixtures of local anaesthetic are off-label, and the solution that you produce has a variable pH. And as we know, pH and pKa can also vary then, and therefore you don't really know what's happening with that solution you created. But they also state that there is lack of evidence of benefit. So I want to handle a few of those. First thing I want to do is handle crystallization. And this paper over here is an interesting paper. They took 7 local anaesthetics mixed with different combinations and adjuvants, and then they assessed the grade of crystallization via light microscopy for 60 minutes. What they found was ropivacaine was worse than bupivacaine when it came to crystallization, and that crystallization increases over 60 minutes. And this picture from that paper shows the type of degrees or grades of crystallization you can get with different solutions. So here's bupivacaine with lidocaine and clonidine, and you can see the rest of the ones that were featured in that publication involved various mixtures of ropivacaine. But the worst was ropivacaine, lidocaine, and bicarbonate, and that was associated with the most crystallization. So my interpretation of this study is, don't mix with ropivacaine, don't mix with adjuvants, and certainly if you're going to create this solution, use it as soon as you've created it. Now also they comment on the fact that bicarbonate seems bad, but we know, certainly in obstetrics, bicarbonate is used quite often without clinical issue. But now it's time to have a look through the evidence. I'm going to start off with this one paper from 2025. If you look at the bias table here, it looks pretty good. This was a systematic review and meta-analysis with 19 trials and over 1,000 patients. And they noticed that mixed local anaesthetic solution reduced the onset time to surgical block, which is great. And this is about eight and a bit minutes or so. It also reduced the block duration, but again, we're not surprised by that. You're taking a short-acting solution and adding it to a long-acting solution. We do not expect that mixture to last as long as a long-acting solution alone. But interestingly, the mix did not reduce the analgesic duration. So that's that's one in the a feather in the hat for the mixers. The other thing to point out is that this paper was a heterogeneous group. It combined upper limb, lower limb and trunk blocks, and by far the biggest benefit was for lower limb regional anaesthetic techniques. This next paper here is another systematic review meta-analysis from 2024. It's 10 trials with 516 patients. Again, look at that risk of bias table, not quite as good here. And in this systematic review meta-analysis, they showed that mixed local anaesthetic may have no effect on block onset. They also highlighted the fact that this was a heterogeneous population, and they said that their evidence was of a very low level of certainty. Again, it showed that the mixed local anaesthetic may reduce the block duration. We're not surprised by that. But interestingly, there was no difference in pain or opioid use at 24 hours. So actually maybe not so bad for mixers, but look, 50% of studies had a moderate or high risk of bias. This other paper here, this is now slightly less trials. This is 7 trials, 358 patients, this systematic review and meta-analysis. Again, they quote the fact that there were 43% of studies that have some or high risk of bias. They looked at bupivacaine and lidocaine versus bupivacaine alone in brachial plexus blocks, and they noticed there was no difference in block onset. And again, the mixed solution had a reduced duration of action. We're not surprised by that, but their final statement was the overall certainty of evidence is very low. These conclusions should be interpreted with caution. So I don't know, I'm not completely convinced by that. And the last paper I wanted to talk about was this systematic review and meta-analysis from 2025. Again, 11 trials, all for brachial plexus block, 569 patients, but look at that risk of bias table over there. They looked at a variety of brachial plexus blocks, they had a variety of drugs that were used and a variety of volumes, and they concluded that mixed local anaesthetic did not improve block onset time. Again, not a surprise that mixed local anaesthetic produced a solution with a reduced block duration, not a surprise. But look, there was heterogeneity in the definitions of block onset across all of the papers. And then, I conclude that's probably low to moderate quality of evidence. So I don't know, if you were to look at the evidence overall, it's heterogeneous. They use a combination of nerve stimulation, ultrasound and paresthesia with varying testing and timing protocols. They combined a whole host of different blocks and different techniques, and they've got variable doses, volumes, concentrations and techniques, and many of these studies have a high or a moderate risk of bias. So, I'm not completely convinced the evidence pushes us in one direction or the other at the moment. But one final word on mixing.
Vincent Chan taught us to do mixing. It is the Toronto Western
Okay, this is a
tradition
mic.
and
Let
culture.
me just get this.
Yeah.
I can't
Okay,
do a
okay.
mic drop. Yeah.
We both learned from Vincent
So,
Chan.
Mic drop.
Yeah.
Vincent
Mixing
Chan,
local
Vincent
anaesthetic
Chan,
is okay.
Anahi Perlas, Ricky Bro, all do 2% lidocaine, 0.5% bupivacaine, and so I do it.
So I would say if it's good enough for Kijin, Anahi Perles and Ricky Brull, it's probably good enough for me. Okay, now let's move on to doses. Again, I'd like to reference this paper here that I co-authored with Kareem and Kijin, and let's have a look at the doses of local anaesthetic. So this is an overall view of some of the doses that you can find if you were to look up various sources, but be aware there are regional variations in these doses, so it's useful to have a framework, but depending upon which source you consult, you may get slightly different answers. This is a good framework that I want you to bear in mind, but there's a few things that you might want to consider when it comes to local anaesthetic dosing. Certainly aim to use the lowest dose required for clinical effect, and caution when you're using higher volumes such as fascial plane blocks. This is certainly a point when you might want to consider using epinephrine to reduce the systemic absorption. Also, be careful if you're using multiple blocks and using multiple routes of local anaesthetic administration, or if you're mixing local anaesthetic. And certainly the thing that I'm very nervous about is when people are using intravenous lidocaine in conjunction with regional anaesthesia, and that's something to be very careful of. But certainly also think about those high risk groups, patients who are pregnant, patients who have cardiac, renal or hepatic disease, or patients at extremes of age. Are there any app recommendations? Well, I would recommend this safe local anaesthetic app, and this QR code will take you to it. The reason I like it is you can select the drugs that you're using. If you're using a mix, you can select the concentration. Once you put the concentration in, you can then also highlight the weight of the patient. And once you've done the weight, you can then go on to select any particular comorbidities that they have, and then it will tell you the maximum dose you can use of each agent. But certainly it's the maximum, assuming you're using the agent in isolation. And then when you put in what you've used, it tells you how much you've got left over to use yourself or how much the surgeon has left over to use. So certainly an app to consider. I do want to highlight this other paper now by John Bailey, Garrett Barry, and Thomas Volk. And this came up with some additional considerations for truncal blocks. They certainly said if you're going to use larger volumes of local anaesthetic, you should reduce the concentration. And they also caution high-risk blocks such as the ESP and the TAP blocks where you can absorb a large amount of local anaesthetic. They also highlight several strategies to minimise the risk of intravenous injection, such as ultrasound guidance, aspiration before injection, using a seeker solution, so you can use saline and inactive solution to make sure you can see where the local anaesthetic is spreading, watching for visualization of local anaesthetic on ultrasound, doing small incremental injections so you don't administer all of your dose at one point, using an awake patient so you might get some of those prodromal symptoms of local anaesthetic toxicity alerted to you, and also they also talk about using epinephrine. Now they have some recommendations on the maximum infusion rates, and they quote 0.4 to 0.5 milligrams per kilogram per hour as a maximum doses for bupivacaine, and 0.5 to 0.6 milligrams per kilogram per hour for ropivacaine if you're using infusions. We'll come back to that in a short while. Now, this is another paper worth considering, worth reading for catheters. They looked at local anaesthetic dosing and toxicity of adult truncal catheters, and this is a narrative review, and they focused on paravertebral blocks and TAP blocks. When they looked at the data, they found that the 24-hour package insert doses were exceeded when they looked at what clinicians were doing in 28% of cases when ropivacaine was used, and in 51% of cases when bupivacaine was used. So they've come up with their own recommended doses here to try and minimize the risk of you exceeding the dose of local anaesthetic, and I would strongly urge you to read this paper to give yourself some guidance. So last but not least, we're going to talk about local anaesthetic systemic toxicity. Again, I want to highlight two papers here. One paper I've talked about already, and one which was published in a special edition of the Anesthesia Journal, updating our understanding of local anaesthetic systemic toxicity. So what is L.A.S.T? What is local anaesthetic systemic toxicity? It's a life-threatening adverse event that can occur after local anaesthetic administration, and we think that it occurs in 1 to 2 events per 1,000 nerve blocks. So if you do enough of these nerve blocks, you may well encounter it. But interestingly, 50% of cases present within 10 minutes, and 75% of cases present within an hour. Now, in terms of how do they present, they can present with either central nervous system presentations or cardiovascular system presentations, or a combination of both. Now, the central nervous system presentations can involve sensory changes such as perioral paresthesia, a metallic taste in the mouth, or audiovisual disturbances, muscle activation, and initially seizures, but higher plasma levels can cause a loss of consciousness, coma, and respiratory arrest. The cardiovascular system can present with cardiac conduction disturbances, myocardial dysfunction, hypotension, and cardiac arrest. So really significant signs and sequelae. What are the risk factors for local anaesthetic systemic toxicity? We can split these into drug, the patient, and the technique. So certainly, high lipid solubility is associated with a high cardiovascular toxicity and a reduced cardiovascular to CNS ratio. And drugs that have a high cardiovascular to CNS ratio may be safer because actually the central nervous system signs present earlier, giving you a warning that something's about to happen. Patients at the extremes of age, pregnancy, cardiac disease, renal disease, hepatic disease, and metabolic diseases are all at higher risk. And the extremes of age, certainly the older you are, the less muscle mass you have, and therefore the less areas you have for local anaesthetic to kind of act as a sink. So therefore you're exposed to more dose of it. In terms of technique, there are certain techniques that are associated with a higher risk, such as paravertebral, intercostal, intrapleural blocks, fascial plane blocks, penile blocks, continuous catheters, and local infiltration analgesia. So you now know the risk factors, you know what the signs are. How can you treat local anaesthetic systemic toxicity? Well, the first thing to do, of course, is stop injecting the drug. Call for help and call for your local anaesthetic systemic toxicity rescue kit. And if you haven't got one, now's the time to make one. Obviously, maintain your airway, breathing, and circulation, give 100% oxygen, and consider Early 20% lipid emulsion therapy. Now, lipid emulsion works not just by absorbing the local anesthetic, but by shuttling it to sort of highly perfused areas, and it also has a positive inotropic effect. Then, if the patient develops seizures, you need to think about controlling those seizures. Benzodiazepines are preferred over propofol. If you need to treat cardiovascular disturbance, use smaller doses, less than 1 mite per kg of epinephrine, and certainly don't use vasopressin. And then you need to get that lipid emulsion therapy in. And this is based upon giving a bolus first, then an infusion. And for a patient 70 kilograms or over, you can give them a 100 milligram bolus to start off with, and then 250 mils over 15 minutes. Now, wouldn't it be great if there was some kind of cognitive aid to help you with this? Well, there are. And this QR code will take you to the updated ASRA cognitive aid for local anaesthetic systemic toxicity, and this again highlights the early use of lipid emulsion therapy. But how do you remember all of this? Well, there's another cognitive aid here. This one is the Stanford cognitive aids, and again, these are really simple, great things to have in an emergency, because you can focus your attention on what's important. And you can see they've put in bold here the doses you can give for the patient sort of 70 kilograms or over. And there is another source here. This is from my colleague Jeff Gadsden. He's put a YouTube short on there about how to treat local anaesthetic systemic toxicity very quickly. And certainly if you follow this QR code, you will go to that YouTube short. That will give you some guidance. And finally, I just want to highlight this one paper that came out very recently. In 2010, these local anaesthetic systemic toxicity advisories were published by ASRA and by the Association of Anaesthetists. And this paper examined reports of local anaesthetic before and after the 2010 guidance. And what they noticed that the reports of local anaesthetic systemic toxicity did decrease post 2010, which meant that we were better identifying it and treating it. But worryingly, the reports of lidocaine poisoning and death increased. Now, we've seen this reduction in the operating room deaths from 47% down to 15%, which is a good thing. But intravenous lidocaine deaths increased from 3% pre-2010 to 27% after 2010. If you have a look at this table over here, you can see this sort of highlighted in a graphical form here. You can see the total events doesn't change that much, but non-lidocaine events and reports of poisoning dropped, but lidocaine reports of poisoning increased. Again, if you look at the total deaths, certainly there was an increase in lidocaine-related deaths. So is lidocaine as safe as we thought it was? Maybe not. We certainly need education for non-anaesthetists who are administering blocks and lidocaine outside of the operating room. But certainly, please be careful. If you're using intravenous lidocaine or multiple interventions of local anaesthetic, you need to think about toxicity. So, in summary, local anaesthetic administration requires planning and thought, and think about those doses. Whenever you're administering local anaesthetic, make sure you have intravenous access, full monitoring, and use ideal body weight to calculate those doses. If you're mixing two drugs, please be careful regarding the maximum dose. Please make sure that you don't use the 100% maximum of one dose and the 100% maximum of another dose. It makes sense to use 50% of the maximum dose of one drug and 50% of the maximum dose of the other. Do not exceed a combined 100% maximum dose. Please also only use what you require to get clinical effect. Just because you're allowed to use 20 cc's of 0.5% bupivacaine, maybe you don't need to for that block to be effective. Use ultrasound when you're using your blocks, when you're siting your blocks. Do small incremental injections, so if some of that is intravenous, you don't inject the whole amount, and consider using epinephrine, certainly for those high volume blocks. But know how to recognize and how to treat local anaesthetic systemic toxicity. So hopefully that's been useful. Thank you very much for your time and for your attention.